This section is about general and superficial features, specifically general examination, first impressions, facial expression, characteristic faces, pigmentation, abnormal movements, abnormal sounds, anthropometry, hydration, the hand, the mouth, the skin, subcutaneous tissues, lymphadenopathy, the endocrine diseases, reticuloendothelial system, and the principles of examination of the systems. In general examination, the physical examination begins with the examination of the patient as a whole. So one's faculties should be very alert from the onset, and while taking the patient's history, one must observe the patient's demeanor. The examination must be carried out as gently as possible without tiring the patient unnecessarily. So the greeting, handshake, or dressing of the patient will give one early impression of the patient's condition. And the gait may indicate neurological or locomotor disturbance, and also the posture of the patient can be very informative. First impressions are very important. On seeing the patient, the first question one must answer is, does this patient look ill? Although this appears to be very simple and an obvious question to answer, yet experience is essential to make a fair judgment, and it's not always possible to define specifically why the patient looks ill. So relatives and friends may draw attention to deteriorating health unnoticed by the professional health workers. Also, observe the patient's facial expression. A look of pain, fear, excitement, anxiety, or even grief may be noticed. For characteristic faces, much can be learned from the patient's facial appearance, and this will allow a spot diagnosis to be made. And once seen in real life and committed to memory, these are often easy to recognize. Unfortunately, many of the so-called classical appearance of disease portrayed in some textbooks are so gross that the student or even the young doctor fails to recognize the early cases. They do not fall into the sin of diagnostic greed in expecting every criterion to be fulfilled before daring to identify a syndrome. The immobile stare and poverty of facial movements associated with the shuffling gait of Parkinsonism. The startled appearance and gross exophthalmos in hyperthyroidism in the young person. The coarse features with large jaws and hands of acromegaly, the big head of Packett's disease, the rash of ophthalmic herpes zoster, Packet mouth of scleroderma, and stiff awkward movements of ankylosing spondylitis can all be diagnosed at a glance. Yes, and as can pale puffy face of nephritis or the eyes of a patient with Down syndrome. In some diseases, a new observer may have advantages, like the slow and almost imperceptible changes in the appearance of myxedema may be even unrecognized by a conscientious doctor who sees the patient regularly for a succession of seemingly unconnected trivial complaints. And a new doctor immediately recognizing the conditions may be astonished by the lack of clinical acumen of the earlier medical attendant. A common feature of illness is loss of weight, and this needs careful assessment. The wasted patient with gaping collarbone, baggy trousers, and tightened belts does not have to confirm his weight loss with documented serial recordings. The patient's demeanor may give clues as to the cause of his weight loss. The inexorable life-sapping progress of the patient with extensive tuberculosis or disseminated cancer may be suspected at even the first sight. The perky, bed-like features of the schoolgirl with anorexia nervosa may provide early clues, as may the restlessness of the thyrotoxic. Anemia is another pointer to organic disease, but may at times be surprisingly difficult to detect clinically. A glance at the nail beds, the fingers may be more helpful. Nevertheless, the only infallibility to anemia is the measurement of hemoglobin level. The alcoholic presents with plethoric and suffused conjunctiva associated with pervading aroma of alcohol, especially early in the morning, and sweating palms and fine tremors. The smoker smells of nicotine, and a quick look at his nicotine-stained finger confirms this. Also, look for signs of self-inflicted trauma in the young. The patient's face may betray psychiatric disease. Depression is probably the earliest to identify. The withdrawn, expressionless, retarded patients with advanced disease is quickly identified, but milder depression may be difficult to distinguish from simple unhappiness. At the other extreme, the hypomanic patient may demonstrate few obvious facial stigmata, but a constant flow of conversation and disarmingly frank comments may all alert the doctor. Finally, local knowledge is very important. Appearances similar to doctors in the tropics may perplex those working in the Western world. Tuberculoid leprosy in an African visitor may confuse a Boston casualty officer, yet it would be quickly recognized in Kumasi, a city in Ghana. The medical registrar in Hong Kong quickly looks for the nasopharyngeal tumor in his patients with cranial nerve lesions. His counterparts in New York may not think of that diagnosis when examining the proprietor of a Chinese restaurant. Pigmentation. The cause of increased skin pigmentation of chronic debilitating illness or even neoplastic disease is poorly understood, but it is mainly due to increased deposition of melanin. In renal failure, deposition of urochromes in the skin occurs. A diffuse telangiectatic mat over the cheeks may be seen in patients with cirrhosis of the liver. Some increased pigmentation of the cheeks and forehead, chlasma, occurs during and fades after pregnancy. The most gross hypermelanotic pigmentation in disease is seen in Addison's disease and with Nelson syndrome in association with extremely high levels of adrenocorticotropic hormone. The pigmentation of hemochromatosis is characteristically slaty gray. The chronic administration of some drugs, such as busulfan, may darken the skin. Patchy loss of pigmentation of the face may be due to vitiligo, a curious disorder linked with the other autoimmune disorders such as Addison's disease, pernicious anemia, and thyrotoxicosis. However, the commonest cause of patchy depigmentation of the skin is bleaching of the face for cosmetic reasons. Inflammatory skin eruptions can also cause patchy depigmentation of the skin, as seen in onchocerciasis infestation. Complete depigmentation of the skin, hair, and navel tracts is normally seen in oculocutaneous albinism. Abnormal movements. Observe any abnormal movements such as cause pale rolling tremor of Parkinsonism, the flapping tremor of encephalopathy due to hepatic failure, or even the uremic twitching in renal failure, and a fine tremor thyrotoxicosis. Abnormal sounds. Pay attention to the patient's voice and speech. Note the hoarseness of voice in laryngitis and a lesion of recurrent laryngeal nerve. Also note the presence of dysarthria and paced, slow, deliberate, thick speech in myxedema. Note the presence of wheezing, rattling, or stridor in respiratory illness. Note the sweet smell of feta hepaticus in liver failure, the sweet smell of acetone in the breath of the patient with diabetic ketoacidosis. Also, malodor from dirty clothes and general soiling occurring in the elderly infirm patients who are unable to look after themselves, as in mentally defective patients. Halitosis may be due to poor oral hygiene or pulmonary suppuration. Anthropometry, note obesity or thinness in the patient. Increase in height may indicate gigantism or Marfan syndrome. Note dwarfism or the presence of achondroplasia. For hydration, assess the state of hydration in all cases of vomiting, diarrhea, sweating, and polyuria by looking at the tongue and assessing the skin elasticity in the anterior chest wall. The hands. The hand provides an easily accessible area with which to start physical examination by contact with the patient. So you look at the color of the hands. The palm is pale in anemia, palmar erythema, as reddening on the thenar and hypothenar areas, is seen in liver diseases. Observe for Dupuytren's contracture, as thickening and contraction of the tendons in the middle of the hand. It is seen in patients with chronic liver disease. Also observe any wasting of the intrinsic muscles of the hand in the nerve or muscle lesions. Also observe any deformity of the hand. Clawing of the fingers is seen in ulnar nerve lesions. Look for the presence of Heberdin's nodes as the bony swelling of the distal interphalangeal joint, and is seen in osteoarthrosis, and Burkhart's nodes as fusiform swelling or proximal interphalangeal joint, which is seen in rheumatoid arthritis. Look for arachnodactyly, that's the long spidery fingers seen in Marfan syndrome, Achard syndrome, and the Mars syndrome, and kindred hereditary disorders of connective tissue. After this, observe for the presence of finger clubbing, which is very, very important, and it occurs in respiratory, cardiovascular, and elementary or gastrointestinal diseases. So, finger clubbing is staged according to its severity. Stage 1, there is increased sponginess of the nail foot. For stage 2, there is obliteration of the angle between the nail and the nail foot. For stage 3, there is increased convexity of the nail in both directions, longitudinally and transversely. And for stage 4, there is bulbous swelling of the distal end of the finger. Examination of the nail may also give diagnostic clues. Note koilonychia, that's concavity of the nail in iron deficiency anemia. Also check for pitting of the nail in psoriasis, splinter hemorrhages in infective endocarditis, and whitening of the nail, that's the leukonychia in hypoalbuminemia. For the lip, note any cracking of the lips, which are more common in harmattan or dry seasons. Red denuded epithelium in the line of closure of the lips, known as cheilosis, occurs in riboflavin deficiency. Angular stomatitis, consisting of painful inflamed cracks at the corners of the mouth, is also due to deficiency of iron or riboflavin deficiency. A torch and a tongue depressor are needed for examination of the mouth. Inspect the teeth for discoloration, caries, and missing teeth. The teeth may be pitted, mottled, and yellow in color in fluorosis, and poorly developed as hypoplastic in juvenile hypoparathyroidism. For the gums, gingivitis is very common and it may bleed. Hypertrophy of the gums occurs in epileptics who are on phenytoin. Painful osteomembranous gingivitis may also be due to recent infection, which is due to a combination of spirochetes and a fusiform bacillus, and this leads to Ankrah auris. Note the soft, spongy, hemorrhagic gums of scurvy, the hypertrophied, bleeding gums of acute leukemia, and the blue line in chronic lead poisoning. Okay, for the tongue, fasciculation of the tongue is seen in lower motor nerve disease, such as progressive bulbar palsy. Wasting of the tongue occurs with lesions of the hypoglossal nerve, as cranial nerve 12, and when the tongue is protruded forward, it deviates towards the affected side. The tongue is enlarged in some cases of primary amyloidosis, in acromegaly, and also in myxedema. The surface of the tongue. This varies greatly both in regard to color and appearance. Variation in color may be due to foods, particularly colored sweets, or may be due to changes in the hemoglobin levels. Central cyanosis is best assessed by inspecting the undersurface of the tongue. Fungiform papillae are small red flat elevations seen on the surface of the tongue, especially at the tip and edges. Filiform papillae are situated in parallel rows across the tongue, and they give rise to the fur. Transient denuded islands give rise to the term geographical tongue. This is usually a symptomless change of no known significance, but some patients can be worried a great deal about this, and they need reassurance about the harmless nature of this lesion. Iron and vitamin B deficiency usually causes smooth, clean-looking tongue from diffuse atrophy of the filiform papillae. Excessive furring is of little diagnostic significance. It usually occurs following a soft and milky diet or in the presence of fever or dehydration. Leukoplakia is characterized by gray, opaque areas interspersed with few red inflamed patches. This lesion is precancerous. The circumvallate papillae separate the anterior 2/3 from the posterior 1/3 of the tongue. They are set in a wide V with its apex pointing backwards and originating at the foramen cecum. Patients may discover these for themselves and are often alarmed in case they suffer from cancer. They only need to be reassured. Congenital fissuring of the tongue occurs in varying degrees but has no pathological significance whatsoever. For the palate, the soft palate with the uvula comprise the posterior 1/3 of the palate. In lesions of the vagus nerve, that's cranial nerve 10, the soft palate on that side remains immobile while the normal side moves up, moving the uvula towards the normal side when the patient is asked to say ah. Note any deformity such as cleft palate. For the tonsils, look for large and inflamed tonsils. The tonsils, in common with lymphoid tissue elsewhere, enlarge to reach a maximum size between the ages 8 to 12 years, after which it involutes. Tumors of the tonsils may occur either in isolation or as part of lymphatic leukemia, or lymphoma. Also, inspect the buccal mucosa for complex spots. That's the whitish areas like sprinkled salt on a reddish background, seen in measles, and also look for pigmentation. Pathological pigmentation of the mouth is seen in Addison's disease. Other conditions giving pigmentation of the buccal mucosa are chronic cachexia, malabsorption syndrome, hemochromatosis, or the rare Peutz-Jeghers syndrome of polyposis of the small intestine with pigmentation in and around the mouth, and particularly on the lips and fingers. Any indolent ulcer in the mouth for which an adequate explanation is not forthcoming and which persists should be suspicious of carcinoma. For thrush, a thrush is usually seen as white deposits on the mucous membrane of part of the mouth. It is caused by the fungus Candida albicans, and thrush occurs in the elderly in association with febrile or debilitating diseases. Thrush is also common in patients being treated with antibiotics, prednisolone, or immunosuppressive drugs too.